Okay, people are just joining in still, but I'll kind of start chatting anyway. This is our last actually neurotrauma webinar before the summer break, so thanks everybody for joining. We have an interesting presentation today by Dr. David Menzies and Andrew Patton. And it's neurotrauma really from a pre-hospital emergency medicine perspective. We've had a lot of presentations and talks on kind of what happens when a patient lands in neurosurgery in Beaumont or in Cork or in Belfast. In fact, we've had presentations from all three neurosurgical centres. So it's really interesting to listen to what happens before patients get to us. What we can do to improve all of these things, and so I'm delighted. Dr. Menzies would be known to a lot of you. He's a consultant in emergency medicine in St. Vincent's Hospital and a clinical need of MICAS, and he's been involved also with the trauma pathways. And Dr. Patton is also an SBR in emergency medicine in St. Vincent's Hospital. So I'll let you carry on from here, David and Andrew. Thanks very much.
Thanks, Wilson, and thanks for having us. Can you hear me okay?
We can, very well.
Perfect. Cool. So yeah, look, these have been really interesting to listen to over the last couple of months, and we thought it might be interesting to just look at a different part of the patient's journey. So we have 3 cases here. We actually didn't know the outcomes of them fully when we selected them, so forgive us if you think there's bias in there, but we only really found out the outcome in the last week or two. We're going to do slightly different lineup or sequence to usual. Andy's going to give a little bit of an overview of, I suppose, the current state of EMS in Ireland, which mightn't be familiar to all of you in a huge amount of detail. And we'll just talk about some of the challenges that arise with the really sick or the really injured patients, particularly when they're not close to a major hospital, and certainly in these cases where they're not particularly close to a neurosurgical unit. And then we'll talk through the 3 cases and maybe try and get a little bit of feedback from you as regards what you think might be the optimal thing in each situation. And then we'll have a look towards the future. Really happy to stop and talk at any time if there's questions in the chat or hands up, or equally we can just keep going and do it at the end, but there's no issue with interrupting with a question at any stage. Maybe just shout out in case we don't see it, if that is the case. I'll give you to Andy first, who's just going to outline the current situation with respect to EMS.
Brilliant. Thanks a million. Thanks for having us on. So I'm one of the SPRs working in Vincent's here at the minute, and respond with the ambulance service and the fire brigade as a volunteer doctor. So just in terms of the background for EMS, I'm sure a lot of it's familiar to you. So we have 2 EMS providers in Ireland. Dublin Fire Brigade, who would cover most of the metropolitan part of Dublin, and then the National Ambulance Service, who cover the rest of the country, and would work with Fire Brigade in doing Dublin as well. FEC, as you've possibly heard, is the Pre-Hospital Emergency Care Council. So they're the regulator who basically regulate the paramedics. So they're the paramedic version of the medical council, but they seem to have a much better sense of humour by calling themselves FEC and then buying the domain fecit.ie. So maybe the medical council could learn a bit from them. So they define basically the clinical levels that exist in the pre-hospital world, and they define what they can offer. So the pre-hospital practitioners you've probably met would be your emergency medical technician. So they mainly work on the intermediate care service, which do kind of inter-hospital transfers. So they'd be non-urgent, maybe repatriation to a nursing home, or, returning a patient from one hospital to another that's, well. So an EMT offers basic life support. They use an AED, can do some basic monitoring, and have some medications listed there. Paramedic then is the minimum standard that you meet on a frontline ambulance. So there'd be a paramedic at pretty much all 999 calls. So they have, kind of wide experience and knowledge, and can do, I suppose, your basic monitoring, a 12-lead ECG, airway management, and have a wide range of medications. And then an advanced paramedic is your ALS, your advanced life support qualification. And the big thing, I suppose, that they'd offer is they have cannulation and interosseous access, which then opens them up to a wider range of medications than the paramedics and the EMTs. So this just gives you a brief idea of what each clinical level can offer. So you see in green ticks there, or the ticks within the green boxes, is what the medications an EMT can deliver. Then the paramedic has a wider array, so some intramuscular antiemetics, something for diabetic emergencies, clopidogrel, a few other bits, and then your advanced paramedic brings in the IV and the IO medications, so for managing cardiac arrest and some advanced analgesia. Pre-hospital care from a practitioner perspective is very CPG driven, so FEC defined clinical practice guidelines. So this would be their one for head trauma. So basically you enter the CPG if the patient has sustained head trauma, it gives you a step-by-step guide. This is what you need to do: maintain their airway, give them some oxygen, control external hemorrhage. And it's very, it's guideline driven, which are written based on evidence. So what we might do is just briefly step through the anatomy of a 999 call. I know it's probably common sense for most people, but you make your 999 call, you get connected to the emergency call answering service. They'll ask you what service do you want, say ambulance, and then if you're in Dublin, you go through the Dublin Fire Brigade, and if you're outside of Dublin, you get through to the National Ambulance Service. So this is the control room in Tala, which is for the National Ambulance Service. They use the medical priority dispatch system. So this is obviously to identify who the sickest patients are and get the resources to them the quickest. So, the first question they're going to ask is the patient breathing. And if you answer no to that, then that's automatically putting them up at the top tier response of an echo response. And it moves down that way in terms of, the next thing is the patient conscious, yes or no. And obviously an unconscious patient is going to have a higher response and quicker response. So you'll get your ambulance sent out to you. The ambulance will turn up, and then it's, as you're probably aware, it's very much catchment driven. So depending on which side of the road you live in, and it's more a Dublin phenomenon than anything else, will determine what hospital you get brought to, and there's very little flexibility there. The air ambulances, then there's obviously 2 air ambulances in the country. So there's one down in North Cork and one in Athlone. Between the 2 of them, they would cover the country. So, the ambulances themselves would say this is a fast ambulance. So they're, again, staffed exact same as the frontline ambulances. They have advanced paramedics who have a bit of an extended scope to provide some more sedation from a safety perspective for transporting patients in the helicopter. But otherwise very similar to a frontline ambulance. And then again, MICAS, which many of you are probably familiar with, will be the critical care transport service that exists. And, they would transport a lot of the patients between intensive care units in the country, depending on what their need is and where they need to go. So with all of that, I suppose the next question is, where do we fit in? And what do we do? So as doctors, we're volunteers with the National Ambulance Service. And basically we declare ourselves as available to the National Ambulance Service, and they can see our location. And when there's something, they identify a serious call. If we're available, they'll call us to come and attend. We're supported, so we're volunteering and operating on behalf of the ambulance service, but then each of us will be supported by a charity who provide the response vehicles and the equipment and basically resource us to provide the service that we do to the ambulance service. We each have a Tetra radio, which is a GPS tracked digital radio. So the ambulance service can see exactly where we are, similar to their own ambulances, and then, determine, depending on an incident, whether, it's worth tasking us. And also, as we're responding to the incident, they can see how far away we are. And, obviously the comms piece is very important with the control room. We also obviously were reliant on the controllers to identify the serious call and there's a sick patient, but also a large amount of the calls we go to will come from a crew request. So the crews, obviously very experienced on the road, have seen a lot of patients and can, usually twig from the information coming through on the 999 call. Okay, this is going to be something serious. Maybe we'll get one of the docs rolling. So crew requests is a huge part of what gets us out to calls. We're a bit sparse. So this is roughly where we're based in terms of, so there's About 7 to 10 docs around the country who will volunteer with the ambulance service, offering, you know, critical care level service. So you can see, you know, we're based in Dublin, Cork, Mayo, and Donegal, and that's pretty much it. There are doctors volunteering at other levels, you know, some at CF4, some at ALS in different areas of the country, but this is more or less the only place that you'll have your critical care service available. What are we offering? We're basically looking to support and augment the advanced paramedics that are working with the ambulance service or working for the ambulance service and the fire brigade. So obviously they have a huge scope of practice themselves, but obviously for certain patients when we arrive on scene, there's that little bit extra experience and skills that we can offer and assist them with managing the patient. And specifically looking at that, you know, a large amount of the calls that we go to, the biggest thing we'll offer is clinical decision making. And, you know, that's just purely based on years of exposure and experience from working in the system, in the hospitals, in terms of looking after these critically unwell patients. We also have a range of advanced diagnostics. So most of us would have ultrasound. A few of the guys have point of care eye stats or epochs to do your point of care labs or your ABG. Obviously, we've an expanded set of drugs that we carry, be it for sedation, analgesia, vasoactive medication, and then blood transfusion. So Dave carries blood in the car. Jason has some available, and Hugh through CUH in Cork. And, you know, obviously we can offer an RSI and some of your, you know, surgical procedures, thoracotomy, that patients might need immediately. The governance all comes from the National Ambulance Service. So they have this pre-hospital physician responder policy. So when we're operating as a National Ambulance Service resource and one of their assets. And so we're answerable to the medical director, Cathal O'Donnell. So, you know, we meet with them quarterly and, you know, discuss any issues that are arising. And all the work that we do is, you know, indemnified or covered under the State Claims Agency. We also have our Irish Pre-Hospital Emergency Medicine Society, which I suppose is, you know, is a voluntary group of us that we're trying to formalise, standardise, set some standards for pre-hospital emergency medicine. And so, you know, we do this through self-audit, case or peer audit, case reviews, and journal clubs. And then, you know, this is it's not a solo operation. So we're also pretty keen on getting our advanced paramedic colleagues and paramedic colleagues trained up to be able to work with these critically ill patients and assist us so that when we land on scene, you know, things go a lot more smoothly. At the end of the day, the goal is try and bring critical care to the patient. So, you know, get the patient's care and treatment initiated as soon as possible, bringing their care forward. And love it or hate it, you know, it's part of fits with Sláinte Care aims, you know, right care, right place, right time. And just finally, I suppose, you know, it's not, you know, there are definitely challenges to it. The biggest one being the ad hoc nature. You know, you saw the map, how sparse it is. You know, the service is very much dependent on the availability of the volunteer doctors, where they happen to be at that time. You know, if you go away for the week, you know, then the area is uncovered unless one of the other docs is around. And that, you know, obviously affects the care, but also then, you know, we're not fully reliable from an ambulance service perspective, being able to know that we're available all the time. And then as well, you know, we're heavily reliant on the EMS team that are there with us. You know, there has to be a strong team of paramedics that are able to assist for us to deliver any critical care interventions. Another big piece, well, not big piece, but a small piece that we are regularly on the receiving end of BFB, some slightly maybe agitated bed managers, ED doctors, emergency medicine doctors, and CNMs when we look to bring an out-of-catchment patient to their already overcrowded hospital and emergency department. But we do our best to advocate for the patient, and thankfully most of these phone calls subsequently, when they meet the patient, usually resolve very nicely. So as you can see, you know, it's that's the background pretty much. There's a lot of, unfortunately, at the minute, there's a lot of luck involved. And, you know, if you're a critically ill patient and you're looking for critical care interventions to be delivered inside of the road, really the stars have to align for this to happen for you. But, you know, hopefully that could change in the future.
Thanks, Andy. So look, we're going to just present 3 cases, and say apologies for slightly doing it backwards, but we felt it might frame the understanding of the cases to have that background out there first, in case some of it wasn't familiar to all of you. So the first case was one that I attended, and it was a multi-victim road traffic collision. A small hatchback car went into a wall on a country road at high speed. It's not terribly recent, but it was out in Drumree in County Meath, so it's not terribly rural, but equally it's not within the M50. There were on-scene resources at the time that I was called, already 2 ambulances, the fire service and the Gardaí. I was about 22 minutes away at the time, and ambulance control rang and asked could I attend, which I was able to do. And en route, I suppose I got a little bit of an update from the scene in terms of the patients that were there. And I knew that the Micah's ambulance was on station in Cherry Orchard and that there was an EMT and a critical care paramedic on it. So while this wouldn't have been a traditional Micah's call, I asked if that was available, could that be sent as well, knowing that there was expertise within that team, and obviously we had the appropriate equipment, which I carry anyway, but it's a little bit easier if you've got a second person working at the critical care level. So they were dispatched shortly afterwards. So when I got there, it's a car versus a wall, multiple victims. There were 3 patients, 2 of them were trapped, and one of them had actually died at the scene as a 17-year-old girl. The second patient was a male with abdominal pain who was reasonably okay. And the third patient was the one that I had been called specifically for. And essentially, on evaluating him, he was in the back of an ambulance already at this stage, having been extricated. He had trismus. He had very shallow, slow resps, so he was having assisted ventilations via a BVM. He'd SATs 98%. His heart rate and blood pressure were fine. He had a GCS of 5, and he had a blown left pupil. And there was no obvious other injuries externally, sort of torso, pelvis, long bones. So we're going to try and just do a little poll here. Hopefully this will work. But we've got 5 questions, and it should pop up in the chat, I hope, in terms of the options. But essentially there's 4 options here, and obviously this is a neurotrauma presentation, so they're slightly skewed, but the options as we would see it would be scoop and run to Connolly, which was the nearest ED, scoop and run to Beaumont, recognizing that he had a reasonable chance of having an operable intracranial lesion, but that's half an hour away. Perform an RSI and take him to the nearest ED, or perform an RSI and take him to Beaumont. So if there's the options, your voting is anonymous. But you can vote A, B, C, or D in the chat now, and it just might be interesting to see what people's take is on that. So I'll give you 30 seconds or so, maybe even a little bit longer to vote on it. And it appears that most people are electing to RSI and taking to Beaumont ED, but there's a smattering of people who say get them to the nearest ED or take them to Beaumont without RSIing them. So that's the dilemma. So I think the audience is strongly in favor of an RSI and taking to Beaumont ED, and that was an option because of the team that was there. That's not always an option. If there's no critical care resource, then you're down to option A or B, and that might well mean you do something differently. Taking this patient to Beaumont ED unintubated would have been possible, but I think difficult given his respiratory physiology and his airway. So we went with option D, and the timelines weren't hugely different. I mean, you're talking about an extra maybe 17 minutes or so to get to, not even that, maybe 15 minutes to get to Beaumont over Connolly. So it's not a massive timeline. So we're able to do an RSI on scene with the critical care paramedic who's familiar with the protocol and the EMT. We use the same checklist everywhere. So it's maybe a slightly expanded version of what you might be familiar with in hospital, but it covers all the bases for doing this in an out-of-hospital environment, and acts, I suppose, as a CRM aid in terms of making sure that the kit is there, that there's a shared mental model, and that we have good backup plans aligned with the Difficult Airway Society, essentially. So he had a straightforward RSI, fentanyl as an opiate, ketamine as an induction agent, and rocuronium as a paralytic. Intubation was uneventful. There was no real change in his physiology at all, which was great. He had some hypertonic saline after that, and was taken to Beaumont ED. I actually can't remember whether I sought a huge amount of permission to do that or not, but it seemed like absolutely the right thing to do. In Beaumont, his CT was essentially not terribly exciting. We were kind of had presumed that there would be an intracranial hematoma that might be suitable for decompression, but he had a small volume of subarachnoid hemorrhage and not very much else going on to explain his reduced DCS. Obviously, the concern there would be that he had a diffuse axonal injury that we weren't seeing on CT. So he went to ICU, he did an ICP monitor in, and that was helpful because by day 2 it was sky high and unmanageable with conventional measures. Repeat CT scan showed a bit of asymmetry, so he had a DECRA. And an MRI on day 7 showed a DAI. He was extubated in day 20 with a bit of a deficit cognitively and muscularly. He had a complex course after that in terms of a cranioplasty, which became infected. But actually, he's now fully orientated, back in college with a negligible right-sided weakness and obviously awaiting a redo cranioplasty. So he didn't quite have the pathology that we expected. But I think clearly benefited from being in a neurocritical care centre, having ICP monitoring and having the ability to have a decompression procedure done when it was clinically indicated. And that was facilitated by senior decision-making pre-hospital, a trained team, not just myself, but obviously the whole emergency response, including the fire service, the initial paramedic crews, and then the MICAS, CCP, and EMT as well. And it worked out really well for him. And I didn't actually know his final outcome until last week, so it's really nice to hear that actually it worked out well. And it could have worked out differently, but I think you're working with limited information pre-hospitally. So that's the first case. I'm going to keep going unless anyone shouts. The second one presents a slightly different version of that. And this is one that Andy and I were both at. This is from Stevens's day, year before last. And it was a call for a 55-year-old female driver, head-on RTC. Actually, what happened was the other car landed on her roof. And the driver of that car was killed at the scene. This happened down in Ferns in Wexford, so it's not particularly close to anywhere. The initial response to that was a paramedic ambulance and an off-duty advanced paramedic officer. The patient was trapped in the vehicle due to significant intrusion, and as I say, the driver of the other car was deceased. The pictures here, they're a little bit graphic, and actually I'll put them up quickly because it takes a while to orientate yourself. If you look at the bottom picture here, the yellow jacket is the advanced paramedic leaning into the vehicle. You can see the orange here is protecting the posts that have been cut. They've already started to cut. This is the front of the other car on top of it. And you can see in the top picture, after they've separated, the amount of destruction that's there. The second picture here is informative because of the amount of blood in the footwell. So you can see in the bottom picture there, large amount of pooled congealed blood in the driver's footwell, and again the intrusion into the driver's compartment there. So a huge mechanism of injury, potential for lots of body systems to be injured, including the brain. What we were faced with here was I'd been asked to respond, which was fine. The advanced paramedic was trying to make decisions about care and destination and realized that this lady would benefit from help. The curveball was I was actually on call for the ED in Vincent's, so you can't just pack up and leave. So I had to phone a friend to see if there's anybody happy at 9:30 in Stevens's night to take over the ED for me for a couple of hours. And thankfully one of my colleagues, John Ryan, was able to and happy to. So that freed me up to do this, which was great. And then I suppose recognizing the complexity of the care, the fact that she might need blood and an RSI, I asked Andy if he was available as well, which he was, and that gave us a bit of comfort knowing that there was 2 critical care practitioners responding to the scene. I'm going to give you over to Andy for what happens next. I stayed with the patient and obviously was the receiving trauma team leader as well, so a slightly skewed perspective in that I knew the whole handover before I gave it to the rest of the team. But I think it was very beneficial for me, and hopefully you'll see for the patient as well.
Thanks, Dave. So the primary survey, when we met the patient, so catastrophic hemorrhage had been controlled by the paramedics. Her airway was patent with an OPA. She was breathing spontaneously on a 15-litre non-breather, SATs of 100%, and no obvious chest wall injury. Abdomen was tender. She had a seatbelt sign. I think it was going across her left breast, and really thready radial pulse. And the advanced paramedic informed us that they had systolics of 50 at the scene, and with some fluid had recovered to 80s. GCS of 7, moving all 4 limbs, and had a 4 laceration, some periorbital hematoma, I think, to the left side. So we might try and get another poll going if you can. So what would you do? And if you can take this in the context of you're the advanced paramedic who's responded down to Ferns, and where would you take the patient? Basically, you know, would you scoop and run the patient to your nearest ED, which is 30 minutes away in Wexford? Would you bring the patient to your nearest trauma unit in Waterford, which is about 58-minute drive? Or would you travel to St. Vincent's, which is an hour and 10 minutes drive? Or have you got a better suggestion? So we might just see if we can get the poll going for those. Another second, so a few coming in. Okay, I presume you can all see the response as well, but if not, you can see the audience very much split between B and C, with B winning. So we've got 56% of people saying that they would go to Waterford as the nearest trauma unit, and 36% saying that they would go to Vincent's. So in this case, what happened? Basically, the advanced paramedic decided that they would head towards Dublin and rendezvous with us in Arklow. And we basically started initiating further treatment with the patient there. So when we arrived, we'd obviously done the primary survey, did a fast scan, found that there was no obvious free fluid in the abdomen. There was good lung sliding bilaterally and no pericardial effusion. She was obviously still cardiovascularly very sick, with reduced GCS. So initiated blood transfusion with 2 red cells and 2 plasma. And then after that had been started, we commenced setting up for an RSI. So with the crew, the patient had received TXA, ketamine, paracetamol, and morphine. When we landed, then we started with blood, and then gave her a 111 or a relatively gentle induction, given her cardiovascular status of 75, 80, and 100 fentanyl, ketamine, rocuronium, and then kept her asleep on the way up with boluses of midazolam and ketamine. And she had an open fracture, so we gave her some ceftriaxone as well. En route, just I suppose of note or potentially of interest, you know, her right pupil was dilated and poorly reactive, so not completely fixed. And I suppose, you know, looking at her, we were thinking, okay, the physiology isn't fully fitting here for maybe somebody with you know, a large lesion with increased intracranial pressure that's going to cause a blown pupil. So could there actually be a retrobulbar hematoma as well, or instead causing this alteration in her pupil, particularly because she had a lot of periorbital swelling around that eye. So just to give you a bit of sense of perspective on the call, so you know, this is the timeline. So the 909 call was made at just before 5:30. The fire service locally were there within 10 minutes. The first ambulance was there about 20 minutes, within 20 minutes, and then they left scene with our patient, or the patient that we were involved with, 85 minutes in, so about an hour later. So you can see obviously there was very, very significant damage to the car. There's obviously a lot of extra time spent trying to extricate her safely from the car and initiate resuscitation. And then when we met her at 7:20, we spent about 10 minutes getting her set up in terms of resuscitation, running through the checklist, getting equipment ready to go. And then the time of RSI was at 7:30. And then left shortly afterwards and arrived in Vincent's 56 minutes later. So you can see there, you know, basically 3 hours from time of injury to the patient landing in the receiving centre. So fairly significant pre-hospital course. Then when she landed in the ED, her CT basically showed some multifocal intraparenchymal hemorrhage and subarachnoid hemorrhage. C-spine was fine, and then in her abdomen she had a splenic laceration, and she had a fracture of her left femur. So this is her CT here. So you can just see that obviously the different areas of hemorrhage. And so she was admitted to the intensive care unit here in Vincent's. Day 4, then she had an MRI, which, you know, again showed the multifocal hemorrhage and, you know, suggestive of a diffuse axonal injury. And she had some areas of infarction as well in her frontal lobe and her cerebellar hemisphere. Day 9, then unfortunately she developed PE and DVT. She had some staph epidermis in her blood cultures, got a tracheostomy, suffered quite bad delirium while in the ICU, but was discharged then from the ICU day 20. So just a few slices of her MRI. So she was discharged then from the ICU day 20, underwent intensive MDT input, and then started fully weight bearing, and she has been discharged home, has some slight cognitive impairment, and is but was deemed well enough that rather than waiting in hospital, she was discharged home to then follow up with the National Rehab Hospital as an outpatient.
I actually saw her at ED within the last month for an unrelated issue, and I think the cognitive impairment was imperceptible to me. So she's done very well. I think the poll was really interesting if you look at the map here. So Ferns, about half an hour to Wexford, an hour to Waterford, and a little bit over an hour and 10 to Vincent's. The AP certainly wouldn't have been comfortable taking the journey to Vincent's without knowing that there was some additional help on the way down. Even going to Waterford over Wexford, I think, would have been tricky given her presentation. I mean, she had blood pressures of 50/30 during extrication. You can see the amount of blood she'd lost externally on top of a bit internally. But actually, paradoxically, now she didn't have an operable brain injury. She was obviously discussed with Beaumont, and it was felt that she could be managed at Vincent's, which as you see, she was. But had she had an operable lesion, or had she had a need for, ICP monitoring, taking her to Waterford would actually have taken her further away from a neurosurgeon. So her closest neurosurgeon in Ferns is Beaumont. Her closest neurosurgeon in Waterford is Cork. We've taken an hour to get to Waterford and then another 2 hours to Cork. Whereas if we get her to Vincent's, we're only another 20-minute hop, should she turn out to have an extradural. She wasn't a patient I think we had enough evidence to say we're going to go straight to Beaumont with clinically, and also she wasn't a patient who was probably stable to go much further than she needed to. We had the luxury of having blood and plasma to temporize things, but I think we were quite relieved to land in Vincent's with her. But I think Ferns is one of those really interesting places where, and again, I talked about it before. We had a case there where the conventional wisdom of the neurotrauma unit mightn't always be the best one for certain cases, and this is a good example where the script doesn't quite work.
Great. We might move on to our final case. So case number 3. So this case, the call came in from the control room, basically a 24-year-old male who's had a cardiac arrest on a rugby pitch. So I responded. We had an ambulance going, which had an advanced paramedic and a paramedic, a fire truck from Dublin Fire Brigade, which is an advanced paramedic, and 4 paramedics, and then myself. So when I landed in on scene, there had been some bystander CPR performed. The patient collapsed, bystander CPR performed, and when the first paramedics or EMS arrived on scene, they determined that the patient had a pulse and seemed to be, kind of potentially having a seizure. So on assessment, the patient was flattened back on the side of the pitch. Trismus, but thankfully no PA in situ, and started performing a jaw thrust. He was immobilized from C-spine perspective, and he had highly irregular respirations. Fascinating pathology to be watching, but equally concerning to see. He was hypertensive and relative bradycardia to what you'd expect him to be after such an incident. GCS at 3, and both pupils were fixed and mid-size, which actually was kind of a little bit disconcerting. So of the history that we got, so after the primary surgery, we went and got a history then from a few of the bystanders. The story was that he had hit his head off another player's knee or possibly a hip, unclear exactly. He had gotten up, staggered off to the sideline, and then collapsed, and he'd been unconscious since then. And like I said to you, given the, he appeared to have some agonal respirations, so there was bystander CPR performed. So, it's a tricky case when you land into that. Obviously you've been told from the 999 call he's had a cardiac arrest. Possible, maybe unlikely. He's collapsed and he's remained unconscious. Yes, he could have a neurosurgical lesion, but obviously the timeline doesn't really fit for a big extradural. He's literally had the bang and now he's down. Could he have had spontaneous, a coincidental subarach? Has he just dissected a vertebral or a carotid? It's really tricky at the time, and trying to work out what your diagnosis is will then obviously help determine a destination. So we might do our final poll and see what people think. So in this scenario, what would you do? So would you scoop and run and go to St. Vincent's ED, which is 5 minutes away? Would you scoop and run and go to Beaumont ED, which is 20 minutes away? Would you do an RSI and go unseen side of the pitch and go to Vincent's ED, or would you do an RSI and go to Beaumont ED? So we might just get the poll going again, and okay, interesting, really, really interesting, and hopefully you can see the results again. So, they're changing. People are changing their mind. Give another second to settle. Okay, so wow. Okay, so 15% of people have said scoop and run, scoop them up, and head to Vincent's ED. Only 5% of people have said go to Beaumont, scoop and run to Beaumont ED, and then we've a relatively even split: 35% versus 45% of saying RSI and go to Vincent's ED, and then another small percentage, or 43%, saying RSI and go to Beaumont ED. Interesting. So I suppose at the time, my thoughts were we're 5 minutes away from Vincent's. If I'm going to Vincent's, it's probably not justifiable to do a pre-hospital RSI here. In a highly lean pre-hospital system where you have a team that are well-oiled machine, absolutely, and it would be the right thing to do. But in the current setup that we have, I don't think that would be appropriate. So anyway, and then equally, are we doing an RSI and going to Beaumont? I'm conscious of what if I've got the diagnosis wrong, land into Beaumont, and actually there's nothing wrong with his brain. He's having a seizure. He's had an arrhythmia, or maybe it's a dissection. So that's when I went for my consultant phone call. So phone a friend. Which is something, obviously I do as part of the governance as a trainee, but something that I would intend to continue doing throughout my career, because by talking to someone that's having a number of occasions objective, who's away from the scene, they can just give you a different perspective. So obviously in this case, 10 o'clock night, thankfully Dave answered anyway, and said, gave him the story. He said, okay, look, best plan seems RSI and go to Beaumont. So that's what we did. The best GCS of the patient was GCS of 4. Just before we put him to sleep, he started having some extensor posturing. So we gave him, he's obviously hypertensive, bit bradycardic. So we went to 200 fentanyl, 100 ketamine, 150 of rock, had fluids running, and then kept him asleep en route with 10 of morphine and midazolam given over boluses. Interestingly, then after the RSI, his left pupil started working, but his right pupil became fixed and dilated. So initially, the two of them had been kind of mid-sized and fixed, which is me thinking of seizure, brainstem, something. Wasn't too sure. This made it sound a little bit more maybe legitimate or isolated the pathology, but again, the time frame seemed odd. So just for another comparison, you have the timeline here. So the 999 call was at 21:37. The ambulance was on scene 8 minutes later, and I was about 30 seconds behind them. Then I made a consultant phone call at 13 minutes in, so assessed the patient 5 minutes, made the phone call, and then we had the RSI done 15 minutes later. So between kind of getting them onto the trolley, getting some access, getting some drugs and everything drawn up, left scene 14 minutes after the RSI. And I suppose the advice that I received from Dave, which seemed entirely appropriate, was make sure you ring Beaumont and let one, get permission, two, / maybe let them know you're coming. So I spoke to one of the emergency medicine consultants in Beaumont. There's kind of hiccups everywhere. I rang the switchboard. They weren't sure who was on call. So then it's kind of phone a friend, which isn't ideal, but worked very nicely. And thankfully, the friend said, don't worry, I'll sort the emergency medicine piece. You phone neurosurgery, dial neurosurgery engaged, getting closer and closer to Beaumont. But thankfully got through, and brilliant SHO, I think, or registrar, who was probably a little bit taken aback when I started talking, trying to piece it together, but very quickly, gathered the picture, and with great reception when we arrived in Beaumont, with the neurosurgical team and consultant ready to go with the patient theatre. So patient brought into Beaumont, went more or less straight to CT, and this was his scan. Which to me was really interesting at the time. But having listened to the presentation by your colleagues in the north about the sports injury and second impact syndrome, that kind of pieces it all together with that subdural. So he went straight to theatre, and then afterwards he went to ICU. Day 2 to day 5, an awful lot of seizures. Day 7, quite severe diffuse encephalopathy. Day 18, fairly extensive infarcts in his brain in the right hemisphere, and also some in the left frontal area. And then day 22 he extubated to high flow. Day 23 GCS to 13, and day 24 discharged the ward, which given those first kind of rocky 7-8 days, really didn't think that would happen. He's had extensive MDT input since then. The bone flap is replaced day 42. He had a vitreous hemorrhage day 48, and then a vitrectomy as a result of that. But currently his GCS 15 has slight loss of power in the left arm and left leg. He's working on transfers with assistance of 2, and continues to rehabilitate with the MDT. So again, definitely not a result that was expected. I suppose just again, it's different case, different perspective. You see there, you're kind of 5 minutes literally around the corner from Vincent's, 20 minutes to Beaumont. Again, it's very different geography, but it does show that I think critical care has a role even in an urban environment. And yes, we say 5 minutes to get to Vincent's, but by the time you've loaded somebody up and getting them back to the ambulance, and you drive down and you unload and you hand over, that time all adds up. And I think anybody who's been sitting waiting for somebody to arrive over for theatre knows there's no such thing as a quick scan. So it's all well and good. We've done it before. You pit stop in the hospital, you think, grand, look, we're ready, I know the system, I have all the contacts, we'll just get a quick scan. It's always going to take you an hour, and then you guys will say, oh, we'll transfer somebody over, or we're leaving in 5 minutes, and half an hour later they're still stuck in the ED for whatever reason. So that is, I think, in this case, the benefit of going direct from scene with the critical care aspect to it.
Thanks, Andy. We'll wrap up shortly, but I hope there might be a little bit of discussion afterwards. But I just wanted to look a little bit to the future about where all this might fit going forward, and also maybe just take a very superficial look at some of the evidence around it. There's obviously change in how trauma care is going to be delivered in Ireland, and neurotrauma is a really important part of that. And I think there's also going to be some change in terms of how pre-hospital care and pre-hospital critical care is delivered. The sort of interventions that we've discussed there are fairly standard, but there has been a lot of, I suppose, controversy over the years, and it's only maybe in the last sort of 5-10 years has been a very established set of guidelines by other pre-hospital services internationally. We know if you intubate a trauma patient without drugs, the mortality is terrible because they're obviously pretty uptunded anyway. Intubating with sedation only is equally associated with poor success and increased mortality. Some of the sort of medication regimes that were used historically have fallen out of favor. So thiol and Sux will be in your classic RSI medications, and I think rocuronium now has pretty much displaced Sux by and large, and at increasing doses to get optimum intubating conditions. Cricoid pressure is certainly de-emphasized a lot as well. There's some evidence that it worsens your view, and not a lot of evidence of benefit. Even in terms of the sedative or the anesthetic agent, I mean, propofol is probably not great in a lot of these patients, particularly if you think of our second patient who had pretty poor hemodynamics. But obviously there's been a concern around ketamine with respect to raised ICP, which has not been borne out clinically. I think people, again, are much more comfortable using that now, particularly if you use a good opioid as well to attenuate some of that hemodynamic response. Pre-hospital RSI in a lot of the cognate physician staff services internationally has a first pass success rate of 99%. That's been proven in paramedic services as well in Australia and New Zealand, and equally there's been some outliers where the success rate is less. Failed intubations are an issue, but what mustn't be an issue is an unrecognized failed intubation. If you don't get the tube in, obviously, there's things you can do, but if you don't recognize it's in the wrong place, then that's a calamity. And waveform CO2 is standard on every ambulance monitor now, and I know is increasingly standard in ICUs as well. What isn't controversial is that if you're going to do this, it needs to conform to a rigorous set of guidelines. The AAGBI have a guideline on pre-hospital emergency anesthesia, and we subscribe to all the components of that, and that's part of the NAS governance. Internationally, this is the San Diego trial, which had the 86% first pass success. It was paramedic only. I think that there was no universal CO2 during that. It's non-recent, and the training wasn't perhaps what it should have been. So while they did demonstrate some outcome improvement, there was also a significant mortality issue as well. So it's certainly not a reference study for a good impact. This is the MICA paramedic only study from Australia, which shows excellent outcomes with a paramedic delivered service. Although the fragility index of that study is pretty small, one patient in the other group would have given you a non-statistically significant result. A lot of us waited with anticipation for the CareFlight head injury retrieval trial study in Sydney. It was a randomized control trial. They didn't reach the recruitment target. They barely showed a difference in outcome. I think everyone's pretty disappointed that they didn't actually prove definitively one way or the other. So here we are. We've got a thing which we know the patient needs in hospital. We don't have evidence definitively that doing it pre-hospital is better or worse. That's the dilemma we are in. If you look at the patient care across Europe, this is a study of nearly 4,000 patients, and all it says is, there's a large variation, we need more research. So thanks for that, guys. Notwithstanding that, the Brain Trauma Foundation issued last month updated guidelines for the pre-hospital management of TBI, aiming to prevent secondary injury and avoid, obviously, iatrogenic injury. There was an interesting observation in that, and that's probably the highlight for me. Fatality rates for all-cause TBI is lower in a rural area or in a metropolitan area than a rural area. It's probably obvious. Your ambulance response time is quicker, your transport time to hospital is quicker, and you're probably going to be closer to a neurosurgeon. So it makes sense. If you get injured in Dublin, your odds of survival are weighted in favour of you compared to elsewhere. They made some standard recommendations on what we should and shouldn't do, but nothing conclusive. Nonetheless, the National Institute for Clinical Excellence in the UK does recommend, and has done for 5 or 6 years now, people with major trauma who cannot maintain their airway and or ventilation should have drug-assisted RSI of anaesthesia and intubation within 45 minutes of the initial call to emergency services, ideally at the scene of injury. So that's a pretty conclusive recommendation from the UK. So in Ireland, we have a national trauma system, which is in evolution. It's made some recommendations around retrieval and transfer. We'll have a collection of trauma units around the country, an MTC in Cork, an MTC in the Mater, and neurosurgery currently in Beaumont. So that's obviously a little bit challenging from a pre-hospital perspective, because notwithstanding the separation of neurosurgery and the MTC in Dublin, the rest of the country doesn't have a neurosurgeon at all. So it's how do we not disadvantage the patients in the Western Seaboard, and particularly around Cavan, the southwestern peninsulas, and Wexford, where even their transport times to trauma units are prolonged. I'm going to skip over a couple of slides here just in the interest of time. But just suffice to say, there's different models. There's paramedic physician models, which are well embedded in many Australasian, UK jurisdictions. There's double paramedic models, which is more of a US model. And there's critical care paramedics, which we're starting to develop here. And we could do a whole other talk on, and I know at least one of them is dialed in listening to this. I'm going to just finish with a fictitious case, which I think summarizes it all. And this is one I've used before. And again, I haven't tweaked it for this presentation because I'm actually really happy that it stands on its own merits in light of all of that. So let's say there's a chap in Donegal, northwest Donegal, and he's a 22-year-old who puts his car into a ditch at 1 a.m. He's remote from anywhere in northwest Donegal. The nearest ambulance is 30 minutes away. It takes them 45 minutes to extricate him from the car. So they've a longish scene time. Then it takes them 40 minutes to get to Letterkenny ED. He's got a flailed chest, a closed head injury. He's hypotensive, tachycardic. So they tube him, they give him some blood, they put in a chest drain, they scan him, and he's got an extradural hematoma and a splenic lac, which seems to have stopped bleeding. And neurosurgeon Beaumont say, we'll take him as soon as you can get him here. And it's now 4:30. What are his options? Well, they're limited. Standard care is back in the emergency ambulance with an anaesthetic reg, an ED nurse, your ventilator monitor, pumps, a bag of blood, and drive south as fast as is reasonably safe. And he'll get to theatre probably by about 8 o'clock. Option 2 is we could look for a helicopter. It will be probably the Coast Guard heli from Sligo at that hour, which would land at the back of the hospital, and you'd have to get an ambulance to helicopter with the anaesthetic reg, the ED nurse, and the ventilator to monitor the pumps and blood in a noisy, unfamiliar environment. And he'd fly south and he'd land probably at Dublin Airport at that hour of the night, or he could land at the football pitch near Beaumont. You'd probably save an hour, maybe an hour and a half, all going well. So you get to theatre a little bit quicker at the expense of some difficulties en route. Option 3 is a non-runner, but had we a MICAS team available at that hour, they could drive up, get him, drive him back, take twice as long. You get to theatre at midday. Pointless, really, but you would preserve resources in Letterkenny and you would have an expert transport team. Option 3 or 4, which would be lovely, we're not there yet, but would be if MICAS could fly down 24/7 with a doctor, a nurse, or a critical care paramedic, or a combination of the above, flying back to Beaumont, landing ideally at the hospital or certainly very close, giving expert care en route and not depleting Letterkenny of ambulance or nursing resources. So that might be not too far away. And if we're going to do that, well, he'll get to theatre at 7, which is at least as good as the road option. If we're going to do that, then well, why not just fly to the field in which he crashed and deliver the anaesthetic, the blood, the chest drain, and fly him directly to the neurosurgeon that he needs. And he'd be in theatre at 5 o'clock, and that might be life-saving or certainly life-changing. So that's kind of a personal viewpoint, but I think it is probably the trajectory of travel. There's a lot of challenges in how we make that happen clinically. It's obviously not straightforward doing this, but there is a well-charted course. Logistically, bringing patients to unconventional destinations outside the catchment area when they're very ill doesn't always find favour, and it's not always obvious at the time. That's the best thing to do. In the polls as well. So that's essentially it, though. We just wanted to, I suppose, provide a perspective that is a little bit different, and sometimes we're operating with a little bit less information than we would like, but we have seen some good outcomes as a result. So thank you, and really happy to have any questions or discussion or run for cover, as the case may be.
David and Andrew, that was an absolutely fantastic presentation. I really enjoyed it. You have had really good points in there. I thought the 3 cases you presented were fantastic, examples. And it's really good for us to see what happens at the scene and between the scene and the local hospital, and then from the other hospital to us. Your first case, which which showed very well in terms of quick delivery, a quick transfer to Beaumont and the intubation on the scene. Your second one was, the other injuries were probably more important, and we was managed in St. Vincent's. And then the third one, again, it was about rapid access to neurosurgery and rapid transfer. I thought it was brilliant. The first part of your presentation was really interesting in terms of the setup and what happens. So am I correct, at the moment, none of the paramedics in Ireland would intubate? Am I right?
They can intubate without drugs, which effectively means you're an obtunded patient, and typically that's in a cardiac arrest or post a cardiac arrest. So there's no drug-assisted intubation or emergency anesthesia currently by paramedics. Now, we have a small cohort of critical care paramedics that we trained up in MICAS during COVID for obvious reasons. And I think that is probably the foundation of a more widespread level of care at this level.
Right. I mean, from our point of view, I suppose we've discussed so much about where patients should go, but you've really clearly demonstrated apart from where patients should go, is how quickly they should get to the right place is so important, and then the intubation on the scene. In terms of the cases that you presented, Donnacha O'Brien's with me, and he looked after the third case that you presented. So I wonder, do you have any comments, Donnacha?
Thanks, Dave. And Andy, thanks for an awesome presentation. I was the guy you met that night, Andy, in the CT scanner. So you rang across and we knew you were coming, and I actually thought he had an extradural based on the right fixed dilated pupil, and we actually had a case on in theatre at the time. Our registrar was tied up, so I just jumped into the car and tore in, and I met you. So the timeline from the rugby pitch to the back of CT and into theatre, as you pointed out, was just absolutely phenomenal. It was 57 minutes, and we just went knife to skin 5 minutes later, and we found a huge subdural hematoma, which was probably kind of even bigger than what it was on the CT scan. And all his sylvian veins and vein of Labe were all distended and engorged and blocked. And you know, were it another hour later, he would have been fixed and dilated bilaterally, undoubtedly. So the actual on the scene and the transfer and the decision to come straight, you know, hell for leather to Beaumont was absolutely brilliant. The whole hospital was talking about it for weeks afterwards. We did a craniotomy. We took out the clot. We put the bone flap in his abdomen. He had a bit of a rocky course for a week or so, but he's actually on the ward. He's alert, obeying commands. He's a mild weakness in his left arm and leg. He's waiting to go to the rehab center, and he's absolutely fine. Cognitively, he's completely coherent, normal IQ, and congratulations, basically.
Brilliant. Thanks very much.
Not at all. Just one other thing. So you guys are doing this as volunteers, as you showed. So is there any plan for funded posts for things like this, so that you're not?
Currently, no.
Right.
I think, you know, the natural evolution probably is, and again, this is a personal view, but Ireland is a small country. We probably can't justify multiple critical care resources doing different things. So I would think the natural course is probably some sort of evolution of the MyCAT service, maybe into two different types of service, but using some of the same people, be they doctors, nurses, or paramedics. Clearly getting that 24/7 is crucial, and having some sort of aeromedical response will be crucial as well. You know, the land-based response ad hoc locally, that'll always win out in certain situations. You know, if your neighbor has a cardiac arrest and you start CPR, you'll trump any ambulance service. So there's always going to be that. But I think for particularly the far-flung areas, advancing the level of critical care, and I wouldn't be hung up on whether it's a doctor, nurse, or paramedic if they have the competencies. And I think the evidence internationally would suggest that any of them can do it in the right model. So if they're well trained, well governed. But you know, I think our current skill set is with a small number of doctors, and that's probably the foundation to grow it on. And I think, you know, it's good to see the good outcomes and to have the positive experience in Beaumont, because we could equally present 3 cases that we brought you that either did badly or ended up having nothing wrong with their head at all. And that will happen, you know. You know, you won't get it right all the time. So I suppose you've got to be prepared to tolerate a bit of over and under triage to get the ones who will benefit most from it. And that's probably another conversation to tease out how we can scale that. You know, it's well and good having a small group of people who can ring Beaumont and have a chat and go, listen, we're going to do this, and are you happy to have them? But as we get bigger and do it more often, it probably needs a little bit more governance and control, but we can figure it out.
Yeah, I mean, a system where only the people who need us are getting delivered to us it probably means that we are under delivering, if you know what I mean. So you would have to have some patients that arrive who don't need neurosurgery, and we have to deal with it. And otherwise we are super selecting, and then you're missing out the patients that could benefit from coming here. So I totally agree. That's fantastic. I don't see any written questions. Does anybody want to put their hand up? There's a couple of my colleagues, I think, on, if anybody wants to make comments. Otherwise, we will finish up, and I really want to thank you for an absolutely brilliant presentation. Thank you very much.
No worries. Thanks a million, guys.
Thanks for having us on.
And we'll wrap up, and as I say, this was the last presentation, and what a nice way to actually finish up the series, and we'll have a break now till September, and see you all back then. All right.
Thanks a
Thanks.
million. Thank you. Take care.
Bye-bye.